Dr. Abu-Farha, thank you for joining us on MD Newsline. Can you please introduce yourself to our audience?
Well, first, thank you for having me. It's a great pleasure. My name is Mohamed Abu-Farha. I am a diabetes researcher based in Kuwait at the Dasman Diabetes Institute. I've been there for about 15 years. I'm a principal scientist and interested in understanding and working on diabetes and its related complication, various metabolic comorbidities, and particularly of high relevance to this meeting with the work we've presented on MASLD or fat liver disease.
Wonderful. Now, thank you so much for just sharing some of your presentation information as well. You gave a pretty interesting presentation here at ADA 2026, and I just want to dive right into it. So at the beginning of your presentation, you showed the Kadim data on obesity and central obesity in Kuwait. Given that starting point, what does that background make you focus on when you think about liver fat biology?
Okay. So thanks for actually mentioning the study name because it's very critical to us. This is a study that we've initiated about 5-6 years ago. And I have to first thank our chief scientific officer, Professor Fahad Mullah, who had a visionary thought of helping and establish this cohort. That this is a cohort that started in 2010. But the 2010 cohort had a limited phenotype. And when Professor Fahad joined us at the Institute, we had the brainstorming session, and then he was very enthusiastic and encouraging to bring those people into the institute and reinvestigate them with increasing the phenotype of the people. Particularly, we've had to add liver MRI. We've done SOTOScan. We've done, and a sub-cohort of them, we've done oral glucose tolerance test, plus a very detailed anthropometric and other clinical parameters that we've added to the cohort to make it very rich and representative of the, trying to conclusive to the disease. And this was actually done in collaboration with Professor Abdulani from Texas Diabetes Institute, who was very influential in driving this work to get a better phenotyped cohort.
What is the central idea you want clinicians to take from this presentation about portal insulin exposure and hepatic fat accumulation?
So I think this is very critical to understand some of the drivers behind the fatty liver disease. And what we've showed here, or what we've tried to demonstrate, is that it might be that distinguishing between the portal insulin and the peripheral insulin is very critical. And this is particularly focusing on C-peptide level. A lot of people focus on insulin level, but the major focus here by calculating the portal insulin is looking at C-peptide level rather than the insulin level, because the liver absorbs the insulin and degrades some of it. So pre-hepatic level is much higher than post-hepatic level in terms of insulin, but C-peptide does not go through this process. So C-peptide itself reflects the original pancreatic beta cell produced level.
And when you discuss the study rationale, you connect insulin resistance, hyperinsulinemia, de novo lipogenesis, and fat accumulation in the liver. How do you walk through that sequence mechanistically?
So in normal people, they naturally will have a higher portal insulin levels. That is it's a natural process, but the liver deals with that, and with no excess dietary intake, this is a normal process that should not cause accumulation of fat in the liver. However, in people with obesity, where you have an excess amount of fat available, or food in general available, the liver starts to accumulate more than it can use. So this starts to build up in the liver, and because of this level of insulin resistance, you have a much higher portal insulin level than what you would get in normal people, which is aggravated by the insulin resistance facts that leads to a higher higher fat deposition in the liver and the development of fatty liver. So basically, we're putting the sequence of the hyperinsulinemia to the de novo lipogenesis in the liver, and then the ultimate development of fatty liver.
When you compare endogenous insulin secretion into the portal vein with subcutaneous insulin delivery in type 1 diabetes, what is the most important hepatic difference clinicians should keep in mind?
So naturally, as I said, the pancreas releases insulin into the liver directly through the portal vein. But when we get an injection of insulin in people with type 1 diabetes, it goes through the peripheries. So the concentration of the peripheries versus the portal vein is very similar. And versus the case of insulin resistance or people with early stages of type diabetes where they still have an active production of insulin, the portal vein concentration is much higher. And the idea here is a mechanistic understanding of the fatty liver disease development.
Talk to me a little bit about the role that ANGPTL8 plays in the pathways you're proposing between insulin exposure and hepatic fat accumulation.
So we have been working on the angiopoietin-like 8 for about 10, 15 years, and we have been one of the early people to realize its role in insulin resistance. We've published multiple papers, close to maybe 25 papers we have published on this factor in particular, showing that it associates strongly with insulin resistance, showing that insulin itself, not glucose, drives the production of the angiopoietin-like 8. And our group and other groups showed that this factor plays a very critical role in regulation of triglyceride metabolism. So what we have is a work in progress hypothesis where initially based on clinical data, we showed that the angiopoietin-like 8 is increased in people with fatty liver. Its level correlates very strongly with portal insulin concentration as we calculated by the C-peptide level. So based on that, we're hypothesizing that the angiopoietin-like 8 could be a link between hyperinsulinemia and the driver of fatty liver accumulation in the liver. And that's what we would like to test in ultimately in animal models to where we can remove the angiopoietin-like 8 in tissue-specific manner and then test this hypothesis to the validity of this hypothesis.
In the insulin clamp study, ANGPTL8 increased in a dose response manner. How did that relationship shape your thinking about insulin signaling and liver fat?
So basically, these are evidence that we've accumulated over the years. And one of the things, as I mentioned in the introduction about the CODIM study, one of the things we wanted to establish is the well-phenotyped cohort. And one of the things we've established is doing the insulin clamps at the Dasman Diabetes Institute, and that was the drive behind the vision of both Professors Abdullani and Professor Fahad Al-Mullah, our Chief Scientific Officer, who were very instrumental in establishing this technique at the institute. And having access to this kind of well-phenotyped cohort allowed us to measure the level of angiopoietin-like 8 across various points of the insulin clamps. So you have a hyperglycemic clamp where you increase the level of the concentration of glucose, and that leads to increase in the level of production of insulin, and we're able to measure across. And in another clamp where we have a euglycemic clamp where we stabilize the level of glucose, but we fluctuate the level of insulin produced to evaluate insulin resistance. And that allows us to see a different level of insulin levels, and we're able to associate the level of angiopoietin-like 8 with this this increased insulin concentration throughout the clamp.
Now, when you put this clamp data together with your liver fat work, how do you connect portal insulin exposure and ANGPTL8 signaling and hepatic steatosis in one pathway?
So the insulin clamp data, particularly when we're doing the euglycemic clamp, which allows us to establish, this is the gold standard method for establishing level of insulin resistance, and this allows us to to exactly estimate, exactly measure the level of insulin resistance in these patients. And then because we know the level of angiopoietin-like 8, we know other factors, then we're able to establish the link between these two. And then we can measure the fatty liver by MRI, or we also use FibroScan to do that. And what's missing here is the de novo lipogenesis, which is a more complicated way of estimating it that was not done in here. But we're hoping to compensate for that through a more clinically mechanistic study that we are doing. And I think of high importance is that we are looking at generating or validating an algorithm that will allow us to, based on calculation, based on mathematical formula, to generate a mathematical model that allows us to predict, or not predict, even get the level of fatty liver and the liver fat content based on this mathematical formula without having to do MRI or the FibroScan. And the association we're seeing is very high, very strong correlation with the FAB score reaching above 90% correlation, which is very promising. So a doctor can have a formula rather than having to do all these imaging techniques, a formula that's based on things that are routinely measured for a doctor's visit, that allows them to estimate the level of fatty liver in these patients.
Just going back to the title of your talk, how do you interpret the lower fat observed in type 1 diabetes relative to type 2 diabetes?
So this is basically the gist of our hypothesis, where we're saying is that people with type 1 diabetes, they will have a lower portal vein insulin, versus people with type 2 diabetes, particularly drug-naive early diabetics, early people with type 2 diabetes. They will have a much higher level of portal vein insulin driven by insulin resistance. And those people will have a much higher fat content as a result of that.
What's the most important practical implication of this work for diabetologists managing patients at risk for MASLD?
I think what ultimately we hope to do is that I'll generate a formula for doctors that way, to give them a very strong and very simple way to estimate the fatty liver disease in people with type 2 diabetes or people with non-diabetic. We actually recently just published a paper. The lead author is Dr. Fahad Al-Ajmi, where we showed that the wrist circumference can show very strong association, almost 86% association with fatty liver disease. So what we're trying to do here is that identify indices that will allow us to estimate the level of fatty liver without having to do the imaging techniques. Imaging techniques can be used to validate this observation, and this only comes from our understanding, or our basic understanding of the mechanism of the development of the disease. And by understanding that this portal insulin concentration is the driver of the insulin of the fatty liver disease, then we're able to show that this formula can be used based on these factors that we're identifying.
How does this work change how you think about therapies that alter insulin exposure when liver fat risk is part of the picture?
So I think this is actually very very good question, because it addresses one point where doctors, and this also actually stems from a clinical trial that we're doing at the Institute. So one of the problems with diabetes, and this is a big problem for Kuwait. So Kuwait has about, sometimes it ranges, some estimates say 25% of the population is diabetic. And therapy is very critical. So when we use insulin, we have to, insulin is not one, it's like there's immediate side effects of insulin, like the hypoglycemia, but there are other long-term impacts of insulin that leads to other issues. And one of them is the fact that it lacks even cardiorenal protection, other than its glycemic regulation, so, and no additional cardiorenal protection. So one of the clinical trials we're setting up at the Institute that already initiated is that people who are taking insulin We want to see if we've developed another formula that looks at oral glucose tolerance tests for people with type 2 diabetes. And if you challenge them with a glucose load, then you're able to establish certain indices that could tell you that these patients don't need to use insulin, and they can be supplemented by two drugs, a GLP-1 based therapy plus an insulin sensitizer. We think this is because this is fundamentally, this is the cause of diabetes. You need to cause, in most people, diabetes is driven by obesity and insulin resistance. So to develop the disease, you have to have insulin resistance, and you have to have um, lack of insulin secretion. So in people with type 1 diabetes, or certain people, there is a problem with insulin secretion. But in majority, particularly people with obesity, there is an insulin secretion and insulin resistance problem. So you need to address both pathophysiological causes of the disease to better understand and to better treat the disease. So an insulin sensitizer and a GLP-1 drug that help facilitate the production of insulin from the pancreas, reduce the burden of insulin by reducing weight, and other mechanism, that could be a good combination that allows better treatment for the disease.
Now, you mentioned, the usefulness of doctors having a formula. And when I think about, having a formula and being able to make predictions in that way, I'm thinking about other studies that have been able to predict things like lung cancer, et cetera, using things like artificial intelligence. I'm wondering if you have a vision, maybe sometime down the line, of how this data might be used to maybe go towards something in that direction. Do you have any sort of ideas of how? Yeah.
Yeah. I think this is ultimately our vision. And for example, I'll reflect on one of the talks we attended this morning, is that in terms of dyslipidemia and insulin resistance, there is no good way of evaluating the level of insulin resistance. There are some proxy measures that are being used, but they are not routinely and necessarily assessed. So it's very critical that insulin resistance estimation becomes a part of an integrated part of clinical care, and in many aspects in many diseases, dyslipidemia in particular, polycystic ovaries, type 2 diabetes, and so on. So once you have this, a simple formula can help them address and allow them to address this issue of fatty liver diseases in particular, but also can be used as a proxy measure for insulin resistance in another way.
Mm-hmm. What's the next study that most needs to be done to test the portal insulin hypothesis more directly in humans?
So basically, one way we can do that is that there are drugs that stop the production of insulin. So there are people with hyperinsulinemia, that is a disease, and they take a drug called somatostatin to stop the production of insulin. And we think this could be done, trialed in humans, where you could look at the development of fatty liver in the context of this drug, once this drug is given to them. So this is a fairly safe, it's a natural product, so that can validate this hypothesis in human.
Wonderful. I'm sure there's tons of amazing presentations and research that's being displayed here at ADA 2026. Is there anything that has jumped out at you at this conference so far that has either surprised you, or anything else besides what you mentioned earlier that has direct implications to your work?
I think it's very. I think people with diabetes are somewhat. It's a disease, so people, you don't wish it on anyone, because it's definitely a long-term disease. But they're very fortunate to live in this current time, because there is multiple solutions for people with type 2 diabetes. The GLP-1 drugs are very well-established group of drugs. New peptide-based therapies and small molecule therapies are coming up. The amylin analogs, or the small molecule GLP-1 agonist. These are great therapies that are being developed. people with type 1 diabetes are starting to have more and more options, more and more options. I think one issue that still needs to be addressed and would be greatly to be addressed in a better way is the need for an insulin sensitizer to be added to this group of drugs. We have an older drug called pioglitazone that has been used, but unfortunately it's less and less used, which definitely a new generation of insulin sensitizer would definitely be much needed for the diabetes therapies that we currently have. But nonetheless, we have a fantastic group of drugs that are addressing multiple modalities of the disease, and also the kidney kidney protective drugs like the SGLT2 inhibitors, or even the GLP-1 themselves, that are really having a huge impact on people with diabetes.
Wonderful. Thank you so much for sharing your research with me, Dr. Abu-Farha. This has been an amazing
Thank you
conversation, and
very much.
thank you for joining us on MD Newsline.
Thank you for having me. It's a great pleasure, and it was really an interesting conversation. And thanks for your great questions.